explained the idea, and somehow I managed to conduct this with all your support and with the management support. So now we are conducting this, we are observing World Psoriasis Day, access for all. So our speakers already gave a very good lecture here. I think it is a good, great thing for the students also, because we don't have much crowd. Because of you, we have created a lot of crowds, and it is also useful to you. You can dissipate this knowledge to your families and other things also. You can create awareness among the public. So whatever we have, whether it is sports, or whether it is culturals, or whether it is a subject, whatever it is, definitely you will excel in your studies. You will be excellent in all categories. Once you have the exposure. So that's what I think you should give the exposure to the students first. You feel the exposure, you feel this occasion, then automatically you will involve in all the activities. So that's what my mind always says. So because we have very good teachers, mixture of seniors and blend of youth and experienced teachers we have. In all subjects, very few maybe not there, but all other teachers are really experienced, and also the blend of youth also there. Take it for anesthesia, orthopedics, medicine, general medicine, in non-clinical side, as usual you know very well. Because they know very well about our first year subjects, because they are seeing every day that HODs and other things. Only thing the hospital side they are not known. They are not known to many of us. So we have very good teachers, very good, atmosphere also. So I always request you to, generally you have to obey by the teachers. Whatever the teacher says, first you obey. Okay, that is the first and foremost thing I want to give advice. Okay. And above all, then I sincerely again, once again, I congratulate and Dr. Arun Prasad. He's one of my favorite students. And we have to give applause to our speakers also. And our medical superintendent, dynamic medical superintendent, you know very well. I wish you all the success, and also I thank all the faculties and students for attending. Thereafter, every month they are going to conduct a CME. I request all the lecturers come forward for any one topic in coming months. Next month, one person, I want to put some agenda. Okay, so better. We'll have some academic activities. Now that is the best thing. You won't forget those things, those moments. That's good for them. And we will also update our knowledge. Okay. Thank you, Nandha. Thank you. Thank you.
Thank you, sir, for a wise words.
We request our ML sir to felicitate our Dean sir with memento. So we request ML sir to speak few words.
respected Dean Sir, faculties of Nandha Medical College and Hospital, guest speakers, and my dear students. Organizing this wonderful psoriasis topic. In fact, I say you are all lucky students since you are here for the first batch. Since when we are students and all, only in the final year we used to go for the CME. But you all have got the thing as for the first time itself, first year itself, you are able to attend the CME. In this psoriasis topic, what we should take home message is one, layers of the skin. That will be a question in your anatomy question paper mostly. So this is a very good topic. So now you are known about the psoriasis. If you see a person with the psoriasis, you will be able to diagnose, oh, this is psoriasis. So this is the first thing you are learning. Apart from the anatomy, physiology, biochemistry, now you are entering the clinical side. In the clinical side, first thing you are going to diagnose just by appearance is psoriasis. Next, they talk about the complications of psoriasis. So now only I also get to know the psoriasis complication, even it is going to affect the heart and is going to affect the myocardial infarction. So this is all latest. When we studied, these things were not there. Now these are all the latest trends. So you should know how to treat the psoriasis. But now, what is the thing? You should know the layers of skin. So that is a very important thing. See, you are cutting the skin, but you think epidermis, dermis. So Ratna Madam has taken beautifully about the skin layers. So that thing you should keep in mind. With this, as Dean Sir told, this CME will continue. We will start to put a thing, and every month we will continue. So I request you all to attend the CME and to gain knowledge. Thank you one and all. Thank you.
Thank you for your wise words, sir. Now we will have a session 3, psoriatic arthritis and overview. Let's invite our speaker, Dr. Paladithin, sir, Assistant Professor, Department of Emergency Medicine, NMCH, to talk about psoriatic arthritis. And we also invite our chair, Dr. Vaidyalikam, sir, and Dr. Jagannath, sir, to chair the session.
morning to all. Thank you for chairing this session. I call upon the speaker, Dr. Palathina, Assistant Professor, Nandha College Hospital, to talk about the psoriatic arthritis.
Good morning. I'm Dr. Baladityan, orthosurgeon from Department of Emergency Medicine, Nandha Medical College. I'm here to share a few words about psoriatic arthritis. What is psoriatic arthritis? By definition, psoriatic arthritis is a chronic, progressive, inflammatory joint disease. Okay, that is associated with skin condition called as psoriasis. The condition can affect both peripheral joints as well as the axial skeletons like spine, and it results in pain, stiffness, swelling, and joint destruction. The joint pathology actually progresses very slowly and can be more nuisance than disabling. Okay, and psoriatic arthritis is considered as seronegative because there is no blood markers to be detected in the blood to diagnose this arthritis. Okay, this is also known as spondyloarthropathy. It's a group of spondyloarthropathy because that's a condition which has two common things. First is there is an arthritis. Okay, another thing is that it also involves ligaments, tendons, and bones. Prevalence, it occurs in 6 to 42% of the persons with psoriasis. Okay, equal prevalence in both males and females, and can occur at any age. The most common age is 30 to 50 years. And 80 to 90% of the chance of having psoriatic arthritis if any first degree relative is affected. Etiology, the main etiology is genetic factor and immunological mechanisms and environmental. Some environmental exposures are also said to have triggered psoriatic arthritis. And trauma. As ma'am explained, Hoffman's phenomenon, the psoriatic lesions which is arising from the scar. And bacterial infections. The main bacterial infection is streptococcal meningitis, which accounts to 30% of the psoriatic arthritis case. And genetic factor has been known to occur in families. And up to 40% psoriatic arthritis have familial history. And 50 times more chance to occur in first degree relatives, and monozygotic twins are most commonly affected. And the role of tumor necrosis factor, the release predominantly by the cells of monocytes and macrophage lineage. These T cells accumulate in the synovium because arthritis, the synovial membrane is destroyed. So how it happens, the T cells actually gets accumulated in the synovium and it produces TNF, okay, and it causes the destruction of the synovial membrane. And that TNF alpha is present in high layers in synovium in case of psoriatic arthritis. Okay, it leads to inflammation of synovium and also enthesis. What is enthesis? Enthesitis. Enthesis is where the place the bone and tendon gets attached. Inflammation of that is called as enthesitis. And in the TNF alpha, they have isolated bone damage is more in research-based transgenic mice. And differential diagnosis, the main differential diagnosis is rheumatoid arthritis and ankylosing spondylosis. This is very important because the treatment entirely changes for rheumatoid arthritis and ankylosing spondylosis. The only common drug we use is DMARDs. Other than that, all the other things changes. Okay? And steroids are contraindicated in psoriatic arthritis, whereas rheumatoid arthritis is the mainstream of treatment. Okay? So only we have to be very careful in diagnosing, and we have to take extra cautions in ruling out rheumatoid arthritis and ankylosing spondylosis before diagnosing it as psoriatic arthritis. Okay, and rheumatoid arthritis, it is symmetric. Symmetric means actually symmetric means both the joints are affected. Like it will not be asymmetrical. Asymmetrical is so like different kinds of joints is affected. But in rheumatoid arthritis, only the similar joints are affected. And mostly it is proximal interferential joints and middle interferential joints. Okay, but distal interferential joint is affected in psoriatic arthritis. And there is a deformity, annular deviation, swan-neck deformity, which are more common in rheumatoid arthritis. And rheumatoid nodules are present in rheumatoid arthritis, whereas in psoriatic arthritis there will be no nodules. And ankylosing spondylosis, it is also known as bamboo spine disease, where the axial skeleton as well as the pectoral skeleton gets fused. And most of the cases, ankylosing spondylosis have HLA-B27 positive. And ankylosing, the male predominance is noted, as well as main spine axial skeleton is first involved. The spine is first involved in ankylosing spondylosis in most of the cases. Classical description of psoriatic arthritis using more and right diagnostic criteria, but thing is that this is not routinely used now. They have changed it, but let's see how they have differentiated this. This includes 5 clinical patterns. Like they distinguished with 5 clinical patterns with the presentation of the diseases. First one is asymmetric or monoarticular or oligoarticular arthritis. And second one is symmetric polyarthritis. Third one is distal interferential joint involvement. Fourth is axial, and fifth is arthritis mutilans. And asymmetrical oligoarthritis is most common type. This is asymmetrical, which mimics low grade of gout, and they have this classically presented with sausage-like fingers, sausage-like swelling in one or more digits. Okay, and usually less than 5 joints are affected, and it is presented with dactylitis as well as enthesitis. What is dactylitis? Dactylitis is swelling of digits with acute, painful, inflammatory changes. Okay, and chronic wherein digit. In case of chronic, the digit remains swollen for long time. Okay, also referred to as sausage digit. Okay, the digits remain swollen. This is the cardinal feature of psoriatic arthritis, where 40% prevalence is there. And feet are more commonly affected, and it is more predominant in radiology. Okay, X-ray changes will be more predominant. And enthesitis is a region where tendon, ligament, or joint capsule attaches to the bone. The inflammation of the region is called as enthesitis. Symmetric polyarthritis is another type, where it follows the rheumatoid-like pattern, and it affects 15% of the disease affects hand, wrist, and ankle. Okay. It is differentiated from rheumatoid arthritis by involvement of the rheumatoid arthritis involves proximal. Okay, but psoriatic arthritis always starts from distal. And main thing is that the rheumatoid factor will be negative in psoriatic arthritis. Distal interferential joint arthropathy is a classical form, but it is less common. Okay, the 16% involvement will be 16% cases. The nail bed will be involved with paranoia and swelling of the digital tuft up to the tip of the finger. Arthritis mutilans is a very rare form, but this thing is like, what is mutilans? Mutilans is complete damage to the any structure, that is called mutilating injury. Okay, so arthritis mutilations, the joint gets completely destroyed, the bones get resolved, and patient will present with these kinds of deformity. Okay, and in radiographic it is observed as penicillin cup finding. We'll see that. Spondylitis with or without sacroiliitis. It affects the 5% and male predominance is there. It can occur in conjugation with other subgroups. It can also occur with other groups like distal intervention or oligoarthritis type. Okay. And the spondylitis can occur with or without radiological changes. So we have to always correlate symptoms with the radiological finding. Sometimes symptoms will be there, the radiological finding will be absent. But we should not exclude spondylitis change, spondyloarthropathy or spondylitis or sacroiliitis. Okay. So the diagnosis is, the diagnostic value should be given for clinical examination first and then diagnostic tools. And the vertebrae are affected asymptotically. The atlantic axial joint is mainly affected and it may show the evidence of subluxation. Okay. And there is also facet degeneration. The Casper's classification, where I think this Casper's classification is now widely used now. Actually, it has 3 points. For the 3 points include presence of psoriasis, that is current history of family history. Current psoriasis has 2 points, history 1 and family 1, as well as brain dystrophy, negative rheumatoid factor, dactylitis, current history, or recorded by a rheumatologist. Radiographs, hand and foot evidence of extraarticular newborn formation. Specificity of this diagnostic tool is 98% and sensitivity is 91%. This is now widely being used for diagnostic criteria for psoriatic arthritis. Signs and symptoms of psoriatic arthritis. Morning stiffness lasting more than 30 minutes. And it is reported in 50% of the patient. In rheumatoid arthritis, there will be not the morning stiffness will also be present, but thing is that it will not be as much as it will not last for 30 minutes or not. Okay. Retching and pitting of nails, onycholysis. Onycholysis is destruction of nail bed. Okay, and some cases nail changes will be there. And patient may present with less joint tenderness compared to rheumatoid arthritis. Rheumatoid arthritis patients have severe joint tenderness. And dactylitis is the main cardinal feature of psoriatic arthritis, which is noted more than 40% of the patients. Eye inflammation. Eye inflammation also is associated with conjunctivitis, iritis, uveitis, another thing. Okay. And in case of most of the cases, the uveitis tend to show bilateral and chronic. Associated comorbidities. These associated comorbidities can be present with psoriatic arthritis, which are psoriasis, Sangstone, SLE, Logan syndrome, Crohn's disease, metabolic syndromes, atherosclerosis, CHPs, depression, fatigue, anemia. I think Ma'am Sir has told more about this fatigue, depression, okay, how it leads to other systemic diseases. And diagnosis of psoriatic arthritis is mostly clinical. There is no single lab test to confirm psoriatic arthritis present. So what we do is we do other tests. HLA-B27, some patients it is 50% of the cases it is found to be positive, but it is not specific. An RA factor will do to rule out rheumatoid arthritis. And HLA-B27 also will do to rule out ankylosing spondylosis. And the main thing is radiology. Radiological changes, X-ray. X-ray. So these are the X-ray changes in the joints, joint destruction and everything. Okay, these joint destructions. You can see. Treatment. What are the treatment options available for psoriatic arthritis? The main thing is patient education. You can't tell go and tell patient take this one tablet and it will be alright. Okay. As the disease is chronic, the treatment is also chronic. Patient should understand that. You have to make the patient understand that the treatment is like not a short course treatment or something. Mostly patient needs treatment throughout his life. Physio and rehab. Physio and rehab to prevent joint stiffness. Okay. If patient has pain and he is keeping the limb like that for one position for long time, the joint will go for stiffness. So to avoid that, we need physio and rehab. Otherwise, pharmacological therapies, we'll see in detail about that, and reconstructive surgeries to correct any deformity. Okay, pharmacological therapy includes NSAID, DMARD, this is modifying anti-rheumatoid drugs, corticosteroids and biological agents. NSAID, it is recommended to control pain, and chronic use of NSAID can have a radiological disease modifying course. But thing is that the main side effect with in the long term NSAID use is gastritis, severe gastritis and CKD. Okay, patient it can cause kidney injuries to the patient because the main side effect of NSAID is kidney injury. DMARD is methotrexate. This is a gold standard drug. It is taken in 2.5 mg to 25 mg per week. The common first line DMARD is to be used, and it is used to treat polyarticular as well as encephalitis and dactylitis. Other DMARDs are sulfasalazine and leflunomide, but these both doesn't have that much positive effect as methotrexate. Okay, biological agents which are recommended by the British Society of Rheumatology, European League of Anti-Rheumatism, and the Group for Research and Assessment of Psoriasis and Psoriatic Arthritis. Actually, bear with me. This thing looks like a Manchester even for me. So, the biological agents, these are always injectables, okay? TNF alpha inhibitor, and etanercept, adalimumab, infliximab, ceftolizumab, and golimumab. Okay, I think the students you might have came across these things like adalimumab in COVID and everything, right? So these things, adalimumab, infliximab, and ceftolizumab have effective in controlling IBD, this inflammatory bowel disease and uveitis, which is associated with psoriatic arthritis. It can be present along with psoriatic arthritis. So this is the recommended biological agents. And IL-17A inhibitors, interleukin 17A inhibitor, that is secukinumab and ixekinumab. These are IL-17A inhibitors, but thing is that if we give this, it may worsen IBD, inflammatory bowel disease. Okay. Same T-cell inhibitor, beta-setup and IL. Next one is targeted capacity. There's also duration, right? Use for replace the DM of this. But thing is that high doses can cause lung closures, that is pulmonary embolism, and serious heart related injuries. The acute is the active enzyme, and the body acts the inflammation within the cells. Can be used to explain people with mild to moderate sensitivity. So moderate psoriasis cannot be used. Usually what is the side of indicated in psoriatic because the psoriasis. The skin lesions, flare of skin lesions. But these are where we can use intra. The most commonly used intrasteroid is acetic ATMG. Use ATMG diluted with 5 ml plus local anesthesia will be injecting directly on the joint, where it gives pain relief as well as inflammation control. And reconstruction this kind of case of mild moderate inflammation. And osteotomy is breaking of bone. Okay. So what is osteotomy is why we do it because of the arthritis. And joint replacement everything. Another thing which is now came to India and is now getting the small joint replacement. We are also doing small joint replacements like interferential joint trend. This has been started before 10 years. Japanese and Western India is getting famous. We usually do this for destruction of the joints and we replace small joints like interferential distal joints, proximal joints and MCPs. And as a conclusion, psoriatic arthritis is always multi-phase disease and with everything treatment goals should be decided for tailored to be for every patient. There is no common plan for every patient. The treatment plan is individual. And also when choosing between options, the impact of individual therapy as well as comorbid such as axial and inflammation needs to be considered because they are to treat commonly. And that will be pathways the MRD because biological therapies are now showing more improvement case of psoriatic arthritis. Thank you.
Thank you, sir. We had a psoriasis. We also highlighting the psoriatic arthritis, polyarthritis. How about the rheumatoid arthritis?
Sir, actually, now it is not. Actually, we can use it to check the control, but it is not used to diagnose because even can make it possible. So it is not diagnosed for. It is just used for to check the control effect of the MRD we are using. That's all. Yes, sir. Patient comes in early stage. We can try what goal of his treatment is. The patient should be kept active. The patient is not active, spinal go for fusion. Patient is kept active, like patient is like more active, patient is having a sedentary lifestyle, patient is more active. And as well as they are running the but the main for ambulance is keep the patient active, keep the joint moving. Sir, part of the main faces infections. Fibrosis much infection is more common in granulocytic. And the thing is that the site of usage. Actually, we not use it for ankle things because we think can cause structure of cellular. So those things commonly used for ankle. Now we are not using those commonly fibrosis much complaint of main complication. Systemic complications, main things like patient will complaints of weight gain, even for arthritis, patient with like long years of steroids. We have patients who are coming. Patient initially be like thin. After the patient faces swelling and because of the weight gain due to steroid use. But thing is that if side effect benefit is more than side effects, we have to consider.
Also, infections are common, sir. Varicocele injection. Infections are arthritis, we don't. At least we only inject in the OPD. We have to do arthritis. We inject directly on create more pain. We have to inject directly into the joint. And also muscle the muscle. Any other doubts?
Sir, actually we have one case. Actually one case.
Nowadays, there's no illegal from the first year onwards nowadays because distance strongly they so first year itself three cases any illegal cases any interesting cases please you can take your own time come to some class so you can explain see the case and it will enter in mind. Here after please all the staff requested because all of the staff you can interact with the first year bracket.
Yeah.
Any conference?
Actually, when you compare to ever seen a patient arthritis, you see a patient arthritis, completely gone. Okay. The small guys will not be as comfortable or as efficacy as your normal joint, but it will be far better than a rheumatoid psoriatic affected joint. Okay. The patient's lifestyle and the quality of life we have to on the right treating the patient. Okay. Once here we don't actually psoriatic arthritis because withdrawal as the disease. So that is why we have to be very careful. We have to diagnose whether it is psoriatic arthritis. No. Side effects every okay. The root for it. How much we are doing. How we are doing. That's depends upon the surgery. Okay.
was in any of the patients. Most of the lady working will have heel pains. They neglect. If they are persistently heel pain or tendonic ulcers or 86, it occurs. Better to have consultation. And always any short-term multidisciplinary approach includes physiotherapists, rheumatologists, and physical doctors. Always a multidisciplinary. Only when the joints or deformities may have orthopaedics without. Other than that, mostly medically. Identified at early stage and managed reversal of changes. And if the cartilage is fully destroyed, it's a reversal of change. And physiotherapy has been playing a majority of patients will not be reinforced. Physiotherapy. What are the physiotherapy is cryotherapy, cold stimulation, and each can reduce the edema, swelling, and active complex for ankylosing spondylitis. Ankylosing spondylitis. What are the main preparations? What we willing for that. But anyway, the spine is going to get. What we can assure the patients is we can make the patient functional by bracing. At least it can use the functional so that they won't have lung breathing restriction. So we can do bracing, being down loaded. We can allow them to use spine in a functional position. And also in rheumatoid arthritis, replacement can be done but very easy. But problem is not like osteoarthritis, rheumatoid arthritis, cartilage, ligaments, everything is getting destroyed. The later you pressure for surgical, not only the bone gets destroyed, also the ligament, everything gets destroyed. So the post-surgical outcome will be very at the later presentation. Thank you.
Any more questions? What is it?
Might be due to secondary to severe. The percentage of bone can be secondary to severe. Not be any answer. Psoriatic age will be much more.
X-ray changes if you join for a long time, more density gets ready. The joint gets plus. Yes, that's what.
Thank you so much, sir. Thank you so much, sir. We are truly great of valid insights.
Dr. White to praise the speakers and Dr. Jagan to provide the Now, these are the felicity and the charity of the staff with certificate and
Thank you, sir. Thank you, sir. Dr. Sir, deliver the vote of thanks.
Good afternoon. I would like to thank the teams, respected teams, MSS, and the management. Always been our initiatives and excellence. I would also like to extend my gratitude to our senior professors who have been guiding lights. I would like to thank our speakers, our chairpersons, fellow colleagues who have taken time out of their vision to raise this occasion with their presence. I would also like to thank our hero, FMO Mrs. Mercy and team for helping. Finally, I would like to my sincere thanks to our students for their participation. Thank you. Sponsors. Thank our sponsors. Max Life Insurance for providing and just to perform, providing. Thank you.
What an uplifting and activity. We extend gratitude to the dean, sir, speakers, and students for making a great service.
to conclude